Madam Chairpersons, colleague surgeons. First, the good news. I retired last year from University of Tamil as Professor of Surgery after 33 years of very satisfying service. So I am now retired, although I still hold the emeritus status from the University of Tamil. Now, first I want to thank the organizers for giving me the opportunity to deliver this keynote address. And when I was asked to choose a subject, I had to reflect back and ask them to give me what were the subjects people usually chose for keynotes. And I was not surprised to find that most of them were forward-looking, focusing on the progress that is made in the science, medical science, and these fields like the one you heard just now. But then I thought my lecture would be backward-looking. And that's why probably this is going to be an exception. It may make some of you, the younger generation people, to laugh, to feel disturbed, even to condemn the practice that we did at one time in our life. But then these are realities. So I chose the subject, surgery then, that was 50 years back, and surgery now as it is today. And that's why I called my presentation a flashback. I'll cover this presentation at these 4 short headings, and hopefully, madam, I hope complete with the prescribed time. I'll present some historical facts followed by my own experience, and then I reflect on the surgeons, their surgical training, and some philosophical facts in surgery. Now, don't blame me to be partial if I tell you the first surgeon on record comes from India. Yes, sir. His name was Shushruta. This gentleman was practicing 150 years before Hippocrates, whom we all worship. 500 years before, 800 years before BC, which makes it 2,800 years from today. And this is all record. This gentleman described surgical practice under these 8 headings, that the excision, scarification, puncturing, explorations, extractions, evacuation, suturing, and he published a treatise which is still available today called Shushruta Samhita. There are various translations available, and the facts I am producing are taken from this particular treatise, so this is authentic. Now, he was known to be the first person to establish an experimental laboratory. He taught his pupils how to practice the excisions and the incisions, or simple things like watermelon, vegetables and fruits. Surprising, isn't it? He also described in this book various instruments. This is an artist's impression of that time on which modern instruments are framed. So our surgical practice is 2,800 years old. A lot has changed since then. Now, this gentleman was well known for plastic surgery. In those days, the treatment for crimes, criminals such as adulteration, what do you call this? Adulteration. Adultery, thanks you, was to chop off their nose and ears. And this gentleman practiced the reconstruction of the ears and the nose. And this is what he is shown here, practicing and showing his pupils the reconstructive plastic surgery. And even today, the pedicle flap used to construct the nose is still known as Indian flap. Goes after this gentleman, the great Shushruta. So, that's the history, 2,800 years. Now, history of medicine is my favorite subject. But if I talk about the history of medicine, what is its purpose? The medicine was primarily aimed for 3 purposes: relief from pain and pain-producing problems, care of wounds, physical, psychological, accidental, incidental, or intentional. And third, the management of infirmities, either congenital or acquired caused by accidents and all sort of troubles. Now the wounds and the surgeons are inseparable, and therefore the history of surgery can simply be called the history of wounds. Now today we are crazy about evidence-based medicine, but 50 years back there was no evidence-based medicine. All that was there was experience-based medicine. And the wounds have been present ever since the man walked on the surface of this planet. And ever since the wounds have been managed. Not by evidence-based. The experience was the evidence. Cumulative experience. And it's based on two simple principles. Clean and cover. Clean and cover. And today's evidence-based medicine has simply reaffirmed all these principles. Now I won't go much on the wounds because that's my next keynote address on wound care. Maybe some other time when the opportunity arises, maybe next year, madam, I do not know, but let's hope. Now the experience-based medicine we talk about, in good old days in the households and even today in the 80% houses in the world, in the developed and developing and underdeveloped countries, I still practice this. That's called grandma's treatment, based on the naturopathy and household remedies. People have used leaves, barks, herbs, spices. You know, tamarind paste, it's a spice, still used. I remember when I had an abscess on my leg, my grandmother took a leaf, put some oil on it, warmed it, put on that and tied. After 2 days, the abscess burst. Simply because there was nothing else available in those villages. You'll be surprised when I had a cut here when I fall, my grandmother burnt a piece of silk from her sari and pecked the wound with that ash. Just sterile. Of course, the wound healed with a scar, but it did heal. When I had patients of intestinal obstruction in my days of training, we used to have what is called turpentine stoops. And if you know what that is, well, I'll tell you what that is. We used to soak a cotton bag in turpentine in water, warm, squeeze it and put it distended abdomen. It was supposed to initiate peristalsis in the cases of adynamic intestinal obstructions and used to relieve. Surprise to you all, never heard of it, but we practiced it. When I asked my postgraduate trainees, tell me something about enema, they said never heard of it. Even those who heard of it I said, what are the types of enema? He said, I don't know. I said, have you heard of retention enema? Have you heard of evacuation enema? Have you heard of therapeutic enema? They said, this is not for us. We can only talk about the transplants and all those big things. These are petty small things not meant for surgeons. No, sir. No. A good surgeon has to know each and everything, including the history. Have you heard of cupping for patients with anuria? I've seen this happening to my own grandfather. They used to take an ordinary glass, put some spirit or alcohol inside, put a flame on that, flame comes, and they put it here on the kidney. As oxygen is taken away, the cup vacuum created, and that causes the kidney to start secreting the urine. This was practice. Don't laugh if you don't believe this. There were no hospitals at that time. Of course, hospitals were there, but they're far away from the people who couldn't afford, who couldn't access. So what was available? What was available was dispensaries, where the patient could walk and get an outpatient treatment and walk away. And what was available there? Have you heard of gentian violet, mercurochrome, red and purple paints? Some of those nodding head of my age probably have heard this. When I have a cut, I walk to the dispensary and he says, which color do you want? And I said, red. He will paint it with mercurochrome. Or a violet. He will paint with gentian violet. They were antiseptics. Nothing more was available. No disposable dressings, what you have today, which cost a lot of money. Mendel's throat paint. How many of you have heard this? Please raise your hand. Mendel's throat paint, only one. When we had those sore throat, granular pharyngitis in the school was very common. We are going to the school, our passing through the dispensary, a compounder will ask us to stand in line, open our mouth, and he will take a cotton swab stick, put it in the paint called Mendel's throat paint, and paint our throat with that. And then we walk off. In 3 or 4 such paintings, sore throat gone. Mendel's throat paint, iodine based. Of course, we all know iodine, tincture iodine, betadine, they are all iodine based. Silver nitrate, I hope it is still being used as a chemical cauterizing agent. Glycerin Maxelf, it was used, I used to do dressing with glycerin Maxelf to remove dead tissue, desloughing agent. It is hygroscopic and it removes the slough. Turpentine, I mentioned. You know something, have any of you have seen a wound with maggots? One. Maggots are living biological creators. When my patient comes from the fields after 7 days of infection in the lower foot or lower limb, there will be maggots crawling in his wound. And it was my job to take them out with the forceps or do the dressing with the turpentine, because turpentine used to kill the maggots. That was the only treatment available. So, what were the landmark events that made the surgery as it is today? And that is observations, experiences and experiments, either primitive or scientific. Don't forget the wars and casualties. And that reminds me, you know, in the Napoleon army there was a surgeon sergeant. And that sergeant reported to the Napoleon that the patients who developed maggots in their wounds healed faster than those who did not have. How did this happen? That was the first experimental evidence-based information. And it was found that the maggots eat away the dead tissue, do not hurt or harm the living tissue. And then of course, everybody heard of Lister. You know Listerine that you use a mouthwash every day? How many of us say that it named after Lord Lister, the father of asepsis and antisepsis? Scientific research advances, industrial revolution leading to today's safe and minimal surgery, and modern consumerism. Everything is recycled, no recycling, everything is disposable. These are the things that have changed the face of the world. Now, the first part. The second part is my lifetime experience of 55 years of surgery as a general surgeon. Now, I can't help but recount this most memorable day. And that day was 3rd December 1967. Can anybody tell me what that day was? I was working in London Chest Hospital as a trainee. And there was a team led by the famous Sir Magdi Yaqub from Egypt. You might have heard of him. He was running an experiment in his laboratory on animals of heart transplant. And the team was very near, very close to it. And then on this particular day, afternoon around 4 o'clock, we got the news, Christian Bernard has done this in South Africa. So we received this news with sadness that we missed the boat, and with jubilation that this is the first great advance of the, not century, but probably history of surgery, that particular heart transplant. Now what I remember on that day was there was a rumor, man, that was going on. Rumor, a story. I can't authenticate this, but I was so impressed by that, I cannot help but sharing with you. After performing this 14 hours massive surgery, Christian Bernard was very euphoric. He went and sat in his office, and he was looking at the jar in which was placed, glass jar, the heart of his first patient called Louis Wasansky. And he was looking at it and reflecting. And by spur of the moment, he put on his white coat and the mask and the cap and walked into the isolation chamber of the critical care unit. And he stood in front of the patient who was awake by that time. And he said, Louis, Do you know what has happened to you? And he blinked and said, yes. He said, you know, you have got a new life? He said, yes. He said, you know, I have given you a new life. He said, after God, I'm the first one who has given a new life to somebody. And this euphoria, he asked Louis, ask what you want, and I'll give it to you. Such was his euphoria. And you know what Louis said? And pay attention to this philosophy. He said, dog, can I have a look at my own heart? Christian Bernard was stunned. He went to his laboratory, brought the jar, and showed to Louis. And he said, Louis, you are the first living person ever since the mankind who has been able to look at his own heart. You see the depth of this statement. This has never ever happened before. No living person has been able to look physical heart at his own physical heart. That's why it was a landmark event. Now, madam, I don't know whether the story is true or not, but it is so impressive that this has changed the whole practice of surgery. And that's the threshold before that and after that. And then from there I went to a medical college hospital in India. Of course, it was a medical college hospital and I worked there as a general surgeon. General surgeon simply means you have to do everything from head to toe. In that hospital, except orthopedics, there were no other specialties. So we performed each and every type of surgery for which we were trained. The problem was, not everything was available. The problem was of availability and funding. We had material, but they used 1 year supply, used to finish in 3 months. What to do for the next 9 months? There were no disposables. Everything had to be recycled. The gloves, the needles, the pegs, autoclave them, use them. Autoclave them, use them. No disposable material was available. Sharps were put in chemical sterilization, like knives, like scissors. We didn't have any endoscopes except the rigid ones. All I had used were the rigid bronchoscope, rigid esophagoscope, rigid cystoscope, and a rigid sigmoidoscope. Flexibles were not known. Fiber optics were not available. Can you believe that operating on my patient, the nurse was struggling to put a thread in the needle. We didn't have ILS needles. Can you believe that we had the supply of brand sutures like coming from Ethicon and all that, but the supply was so short that within 3 months the supply was over. How to operate after that? So we used to go to the market and buy the reels of cotton thread which is used on the sewing machine, the silk and the thread, cotton thread, autoclave it and used it. Don't laugh, my younger generation people, but these are facts. And one of my colleagues published a paper on this, that with this thread in the brand sutures, there was no difference in healing or the infection rate. Economical. Necessity is the mother of invention. This is what we did. When we have to apply a plaster of Paris on it, because we had to do it, on our patients, there was no plaster available. All that we had was a pack of roll of bandages, which we cut and spread, take the plastic powder, spread it on the bandage, roll the bandage, take some warm water, soak it, squeeze it, and apply on that. Ready-made plaster, we had to do it. X-rays were available, but the scan was unheard of. Today, first thing a surgeon sees is the scan before even he sees the patient. At that time, we saw the patient first and didn't worry about scans and no scans. Even the X-ray films were very few. Only screening was sufficient. Only unipolar cautery was available. Blood was in short supply. And some of you remember, I don't know all of you, when we used to take round, whether in UK or in India, we walked behind the professor. Only 2 people were allowed to walk by the side of the professor. The head nurse on this side and a ward boy with a bowl of Dettol in his hand and a towel on his arm. Every time the surgeon will see a patient, he will dip his hand in the bowl of Dettol and wash or wipe with the same towel 60 patients. And when they did the research in 70s, they found that that bowl of Dettol and the towel were teeming with bacteria. The practice was given up after that, of course. But then that was the practice, because that was the accepted norm at that time. So we did everything under those circumstances. As for me, what we were trained for, we did. I did burr-holes for middle meningeal hemorrhages. I did elective thoracotomies for thoracic injuries. Because I worked in London Chest Hospital, I removed the lobectomies, pneumonectomies, pericardiectomy for constrictive pericarditis and so on, all GI procedures. Kidney stones were rampant. Can you believe that enucleating the prostate in a Freyr's operation? Some of you might have heard this, some of you might not. But very common. Every week there would be at least 1 or 2 prostatectomies by the Freyr's technique. Simple, blind. Your finger is the only guiding thing. Pediatric, plastic surgery. Because there was no plastic surgeon, no pediatric surgeon, no thoracic surgeon, no neurosurgeon, general surgeon. Everything. Except, thank God, there was an orthopedic surgeon. So based on this, I wrote 2 books. One is called The Surgery the Way I Teach, because teaching is my passion. And At Last of Surgery, which is a collection of what I have seen in my practice. And they're available on, freely available on Science Publishing Group website. Anybody can download them. Now, what I am going to show now is the collection of the patients. Kindly appreciate the magnitude and the width of the variety of the patients. None of them, I assure you, is from Google. It is from my own personal archives. Just look at them. Hydrocephalus, cystic hypo, gastrosis, omphalocele. I had to deal with it because nobody was available. Either I do it or nobody does it. Hospital is miles away. Even if my hospital is near, patient can't afford. No accessibility, no affordability. Roundworms. How many of you know that yesterday Nobel Prize for Medicine was awarded? Please raise your hand. Any of you know that? Well, thank God. How do you know who was awarded this Nobel Prize for Medicine? Nobody. 1. 3 people. And they were William Campbell, Santoshi Omura, and Yu Tu from Japan. And do you know what it was awarded for? Pioneering treatment of roundworms and malaria. These roundworms were relevant then, these roundworms are relevant today. Because in my practice, at least 1 or 2 child every week, I used to see with intestinal obstruction, gangrene of the bowel, and thousands of worms which I have to take out as spaghetti from their bowel. And of course, I published papers in the Journal of Surgery on my hypothesis of roundworms and what they cause, how they cause, and all that. But that's again subject of another keynote address. Strictures, fistulas, urinary fistulas, complete rectal prolapse. I devised this surgery for this complete rectal prolapse called anterior colorectal anterior colopexy modified Lahore's technique, where we put the sigmoid colon up, anteperitoneal behind the rectus sheath, and it used to hold it down. It's published in Indian Journal of Surgery. Have you seen such infections? Have you heard of Cancromoris? Have you heard of Phagedina? Younger generation, trainees? Have you heard of Fournier's gangrene? Have you heard of Melanie's gangrene? We heard of it. We learned it and we saw it. This is cancrum oris. The whole cheek is eaten away. It's a symbiotic gangrene caused by aerobes and anaerobes together. This is a septic vat gangrene. This is fetidine. The penis is eaten away by the gangrene. This is a Fournier's gangrene. The scrotum skin is eaten away by the gangrene. I assure you, none of you would have seen these pictures. I have seen. I have dealt with these patients. That's why I call it flashback. Have you seen these pictures? Madura food comes from South India. Filarial. Elephantiasis. These are archives. I collect them because I have seen them. I have dealt with them. Congenital Milroy's disease, lymphedema, both brothers. Acquired lymphedema by filariasis. Even today, no treatment is available. Vascular disease is very common. Berger's disease, Raynaud's disease. Massive tumors, parotid tumor, lymphomas, thyroid cancer, cancer breast. Now, one of the most mutilating surgery is radical mastectomy. The only more than this mutilating are the thoracoplasty, which we did for TB, which I also did many, pelvic exenteration for uterine tumors, and forequarter and hindquarter amputation. Take away this, take away this. Mutilating. Now this surgery was so mutilating, but that was the only surgery well known to cure the cancer breast. All gone today. Today we have the minimum invasive, conservative, breast conservative surgery. But at that time, if we do breast conservative surgery, my professor would have failed me. Because when I did this operation, he was watching over me. And I was raising the flap. He was so furious because I was not making the flap thin enough. Every microscopic lymphatic has to be removed from the subcutaneous tissue. And I said, sir, the flap will necrose. He said, don't worry, we'll graft it again. But we don't want to leave a lymphatic for recurrence. And in spite of this was the picture 6 months later. No surgery was perfect for cancer breast. Now, of course, we can hope for a cure. But that time, cure was unheard of. Chemotherapy was extremely rare. Such tumors, bone tumors, soft tissue tumors, and the magnitude of surgery that takes from the general surgeon, cancer esophagus, inoperable. Take the colon, connect to the esophagus. Why to open the chest or the abdomen? Just take it from the abdomen, put it in front of the sternum, connect it up here. Pre-sternal, gastro-esophageal colon transplant. Patient eats, food is stuck here, he just propels it down, it goes down. Total cystectomy, vat ileostomy, without blood. Rare suture materials available. Still, surgery was possible. Plastic surgery, because there are no plastic surgery available. Cheek tumor involving the mandible, remove it. Hemimandibulectomy. Take a flap from the forehead and put it there. Fashion it later on if it looks bad. Plastic surgery, this is the cases that I perform. I am not a plastic surgeon, but as a general surgeon, we did all this. That was, I call, handicap surgery. 10 years of handicap surgery made me collect all these pictures. And then fortunately, I moved to the surgery of effluence because I moved to Saudi Arabia, King Fahd Hospital, University of Dammam. And there, of course, things were different. Different in what sense? I asked for one suture material, nurse opens 10 packs. I say, I don't want this catheter. I said, no sir, throw it away, I'll get another one. And by the time I finished one case, I told my nurse, with this material, I would have operated 10 patients back home in India. But disposables. Cost is no problem. Take whatever you want. And that's why I call surgery for effluence. Totally different experience what I was used to. We also faced this Gulf War while working there. We have to be ready for chemical warfare, part of my flashback experience. Of course, teaching is my obsession. Even teaching goes to that extent that when the number of students in my university tripled, the space was still the same. So I had to teach my students, ladies are laughing there, sitting down on the floor. They didn't mind, I didn't mind.
Time, please.
Yes, ma'am. A few things about the surgical training. Every surgeon should be a physician first. Must have a solid foundation of basic sciences. You cannot do, anybody who does not know surgical anatomy has no business to do surgery. Surgeon is the only one who interprets the live pathology. A pathology sees it in the jaw. A surgeon sees it living pathology, and he has to know whether this tissue is inflamed or not inflamed. A surgery training is a long and continuous process. And this is a recent research published about the learning curve. The older you are, it takes longer for you to learn. Of course, operation theatre is the only theatre where there is no rehearsals. Each case is your examination. Either you pass or you fail. You cannot take risks. So, the art of surgery is best learned by apprenticeship. Learn from the masters. Just learn from them. Don't blindly follow them. I learned even from nurses and compounders and technicians. Practice their skills. Remember, there may not be a second chance. And the patient trusts you to put a knife on them. Don't betray their trust. What is a good surgeon? The one who has anticipation, attention, and concentration, who has patience and perseverance, who knows when to operate, but also knows when not to operate. It takes more courage not to operate. Knows the limits, avoids adventures, seeks assistance, and ready to adapt new techniques and appreciate the learning curve. Be human, control your expression, impressions, interactions, overtures, and be frank about the outcome. Don't misguide the patient or the relations. So, please remember, to err is human. Accepting responsibility is also humane. Always think of the patient first and follow the dictum. If you cannot do good, please do not do any harm. Definitely say yes to evidence medicine, but don't ignore and don't condemn the experience-based medicine. Adapt to surgical practice according to circumstances. I give you an example. One surgeon refused to operate because ligature was not available. He did not do the anastomosis because he could not do by hand. He needed the staplers. If they are not available, he called me to do the hand surgery. Now, that's the stage of affairs today. So, don't let longevity lead to more infirmities. This, of course, with the critical care. And I believe, always say a prayer. It may never do good, but it will never do harm. No harm in saying a prayer before you put your knife on a patient.
Excuse me, your time is
Yes,
up.
ma'am, I have gone. So, with this background, ma'am, let's not undermine our achievements. Let's not overstate our failures. With this, I tell my colleague surgeons, please let us search on. And I leave you, I started with India, and I leave you with Indian traditional prayer. Let everybody be happy, let everybody be healthy. And that should be the dictum of every medical practitioner.
Thank
Madam,
you for
gentlemen,
your
thank you
nice
so much.
presentation.
Thank you so much.
Does anyone have any question or comment?
Thanks so much, Professor Shyam Parashar.
Can you take your question?
Actually, I have two questions. The first one is, you have presented a lot of unusual and rare cases. I'm just curious to know, how did you deal with these cases long time ago, especially we didn't have all these tools and all these antibiotics and all these means to adapt and to treat these rare, unusual cases. How did you do that long time ago?
I didn't say I operated on them. I didn't say that. I said they presented to me. and I did what the best I could do. For instance, the hydrocephalus. I didn't have any training to deal with that. The patient with the cancers, I could manage. I did extensive surgeries. The patient with the lymphodemas, I could manage them. So all I said, this is an archive of the cases that presented to me. Cystic hygroma, I did injecting boiling water in those days and waiting. It reduces in size as the child grows. So we had the options. Not all of them required surgery, and not on all of them I could do surgery. I didn't say that I operated on them. I said, these are the cases I have seen in my practice. Thank you.
My other question is, I always hear my colleagues who belong to the old surgical school always criticizing the modern surgery using staples and other these tools. My comment is, yeah, I agree that we have to tailor our surgery according to what we have. But I think these tools have facilitated our time and made our operation much easier.
Yes.
I think we must be thankful also, not always criticizing.
I appreciate that. Yes, the marvels of surgery have made surgery safe, life better, and there is no doubt that more we advance, the better surgery becomes. But my question is, don't get limited by this. Keep the options open. If you can't do this, you should have the options. Skills, of course, that comes from the skills.
Yeah, Doctor, I admire your experience. It's really very nice. Presentation, actually. The question, we're I'm middle age. It's not.
Go ahead.
Anyway, just I would like to hear from you how the new generation, or like surgeon like our age, can accommodate. We have learned some procedures. We used to do it in confidential. How the surgeon can be shift himself to other procedures, like advanced procedure. Sometimes some surgeons have difficulty to change. So, what's your opinion?
It's difficult, sir. Good question. I have my personal experience. In '89, when the laparoscopic surgery was first started at King Faisal Specialist Hospital in Riyadh, I was nominated for my department to go with my 2 postgraduates. And the team has come from Dundee to teach this on the modules and then on the patients. And they found that my trainees were learning faster than I was learning. And when I came back, my chairman asked, step back and let them take over. And I stepped back. So you're right. The Harvard study shows the older you become, it's more difficult. Learning curve is longer, more difficult for us. It doesn't stop us from learning, adapting. But we must have our limitations and appreciate that. Yes, thank you.
Thank you so much, Professor Shyam Parashar. I take the immense pleasure to invite Dr. Thiam Silva to facilitate a key moment of Professor Shyam Parashar. Thank you so much.
Very nice presentation, Professor.
Thank you so much for coming
Doctor.
today.
Thank you.
Well, I must thank you for your patience, because one gets carried away when one talks about personal experience. I must have overshot my time, but then, you don't
Enjoy it,
so
yeah.
I should know where to stop. Thanks for your patience.
Very good sharing. Thank you, sir.